And I am delighted to tell you that we will continue, and we have wonderful plans for 2024 already. We would love for you to send in your recommendations, your own presentations. But today we have a great presentation lined up by Dr. Kruse-Diehr. And after some logistical slides, I will hand it over to him to talk about his work. So we are very excited to have you here. Thank you so much for joining, and thank you for your ongoing or new interest. So the presentation today will focus on the Practical, Robust Implementation and Sustainability Model, or PRISM, and how Dr. Kruse-Diehr and his team used it to identify determinants of a statewide diabetes learning collaborative in Kentucky and made adaptations. And so he will talk a lot about that. I will start with news and updates, introduce Dr. Kruse-Diehr, and then hand it over to him. So again, as I mentioned earlier, Ross, Kara, and I have a nice lineup already for this coming year, but we have plenty of spots still available for you and your presentation. If you have recommended presentations, please send those in. In the meanwhile, we have plans to see Dr. Prajakta Atul, who is actually now director of a Dissemination and Implementation Science Center in New Mexico that just started. And she will talk about Fidelity and its relationship to effectiveness, adaptation, and implementation, which is based on actually the book chapter by Bronson and colleagues. So we are very excited to have her in February. And then April, we will have Dr. Dave Buller and his team talk about adaptations for an evidence-based occupational sun safety program in Southwest Georgia. And those of you who followed his work know that this is something that he has been carrying on for many years now, and incredibly successful in actually getting funding for sustainability work and now adapting it to other contexts. We also wanted to let you know this is not directly related to this group, but some of you might be actually interested. And I see actually one person at least who is in the program or was in the program. This is the D&I Science Graduate Certificate program that we offer through the University of Colorado. And if you are interested or you have colleagues who are interested in getting graduate education, this is a fully virtual synchronous program. And there is an informational webinar January 10th that you can participate in. Please pass on this information to those who might be interested. And Kara is wonderfully adding these links to the chat as well. I did forget to encourage you to check in. So please put your name and affiliation into the chat. We will not have time to go around and have everyone introduce yourself, but please just say hello via chat. And then we can go to the next slide, Kara. So not to take up more time, we are going to do the introduction and hand it over to Dr. Kruse-Diehr, who was kindly agreeing to this presentation on a very short notice. We saw he was presenting on this, and I was aware of it at the D&I conference, and we thought this would be a nice way to start the year. Dr. Kruse-Diehr is an associate professor in family medicine, family and community medicine, also the associate director for implementation science at the Center for Health Services Research, and the co-director of the CCTS Center for Implementation, Dissemination, and Evidence-Based Research, or CIDR, and finally the director of the CCTS Community Leadership Institute of Kentucky. He is an implementation scientist who's funded research through NCI, NIDTK, Anthem, applies determinants and outcomes frameworks to health systems and behavioral health interventions in organizational settings. His primary research program focusing on increasing colorectal cancer screening rates among populations disproportionately affected by cancer, such as African Americans, rural Appalachian Kentuckians, in clinical and community sites by matching novel implementation strategies to stool-based colorectal cancer screening interventions. And secondarily, and that's the focus of today's presentation, he conducts research on the implementation of diabetes patient self-management interventions, which focus mainly on the mechanisms of peer support, tailored education, and patient needs that address social determinants of health. And for full disclosure, I had the honor to be working with some of this work, actually both of these, with Aaron in different kind of contexts. So I've been really enjoying getting to know his work, and we are excited to have him present today. Erin, thank you so much for accepting to start us off in 2024. Let me hand this over to you.
Thank you so much for that wonderful introduction, Borshka. I appreciate it. Yeah, Borshka and I have been working together on a number of projects now for 4 years maybe, or something like that. And I'm really honored to be here to present to you all. And I'm a little bit nervous because Prajakta follows me next month, and I've heard her speak a number of times. So I'm a little, I need to find a way, Kara, to make sure that I'm on this list so that I can come and listen to that one next month, because that's going to be really good as well. And congratulations, Prajakta, on your new role. No, Prajakta. So I'm going to go ahead and see if I can share my screen here. Oh, did I do that? Did that share? Nope, that just completely messed me up there. Let me see. All right, I'm going to try to share my screen before I do this and make sure I can do this. You see do you see the regular view, or do you see some weird presenter view?
We are in presenter view right now.
Okay, let me see if I can do this. I would think that by now I would be better at figuring. Wait a minute, maybe this works. Does that work? Or do you still see presenter view?
No, I think I am looking at the right view, and it says subtitles aren't currently available, which might be my setting, but everything else looks normal, looks great.
That could be your setting. I don't know anything about that, but I think we're good, which is a miracle, because normally when these things don't work, they don't work for a long time. So, all right, we're ready to go. As Borshka said, yeah, I'm going to be talking a little bit about using PRISM in terms of identifying implementation determinants and how those determinants were used in some of the previous iterations and ongoing iterations to determine implementation strategies and adaptations for this statewide diabetes learning collaborative that's now been going on. And we are currently in its third iteration. So some of these determinants that we discovered came from that first and second iteration here in this case. So before I go into the background, just to give you a little bit of a background on what the Diabetes Learning Collaborative is it's a facilitated collaborative that primary care clinics take part in, that's facilitated by the Kentucky Regional Extension Center, or in this case, you'll hear me refer to them as KREC a lot of times throughout this presentation. And they are guided by the IHI breakthrough model. And the idea here is to do a small test of change via Plan, Do, Study, Acts in order to increase the number of patients that are referred to diabetes self-management education, DSMES, and support. And hopefully a long-term goal, of course, is to improve patients with diabetes outcomes, which the primary outcome clinically in this case is lower A1C levels. So they do these facilitations to try to work with clinics to try to figure out things that they need to do. And then there's also a third group that's involved in this, sometimes not in this current third iteration, but in the first and second iteration. They also work with the health departments. Most clinics do not have their own DSMES services on board. So in this case, what they do is they actually make referrals to the health departments that have this Healthy Living with Diabetes team, and they do the DSMES services. So it's kind of like a little triangulation in that case. A few clinics that are a little bit larger and have their own hospital systems, for example, they do have their own DSMES that they're able to charge to insurance on that. And of course, that's the route that they usually go. But the vast majority of the clinics, and at least the first and second iteration of the Diabetes Learning Collaborative, did not have that. So they use these Healthy Living with Diabetes teams at the health department to provide those DSMES services. The third iteration that we're in right now, just coincidentally, both of the clinics are larger systems and they do have their own DSMES services. So we're not working with the health departments right now directly, only indirectly. But for what I'm going to talk about today, you're going to see kind of all three of those groups. And I only say that to mention that it's kind of interesting, because you have KREC that's facilitating this work with clinics, and then you have clinics that are testing these strategies and changes with their patients. So there's kind of various levels of implementers when you're thinking here. You can think of KREC as being an implementer of the DLC itself, And then you could think of the clinics as being implementers of the various different strategies and the different tests of change that they're working on with the KREC employees and the KREC folks and that. So that's going to kind of, I'm giving you all of this background information to so that you understand some of the data that I'm presenting, because you're going to see some different levels of data here in this case. So just a bit of a background on the study itself here is that DSMES is evidence-based, it's cost-effective, it's been shown over and over to improve outcomes for patients who have type 2 diabetes, but it remains underutilized despite the fact that it's free of charge and available across Kentucky. So it can be billed to insurance for these clinics that have their own DSMES services. But for patients who are underinsured or uninsured, the health department still provides that for free. So it's free of charge for anybody who wants it in this case. But unfortunately, patients don't know it exists. Oftentimes, clinics don't know it exists. And even if they do, it's not necessarily on their radar to make those referrals or to follow up to make sure that patients get those referrals. So what our team is doing is partnering with this statewide quality improvement advisory organization, or KREC, as I mentioned before, that's now implemented 2 iterations of the DLC and have done learning collaboratives with various other issues, including colorectal cancer screening and some various other things. So this is kind of their main thing that they do with these clinics, is implement these collaboratives. And this early pre-work that I'm talking about here, some of this baseline data, was the goal was to identify implementation determinants and explore their effects on outcomes, so that we can put some of these lessons and some of these strategies into play for this 3rd iteration and see how they affect re-aim outcomes, which we have not collected those data yet because we're still only ending in the 1st year here, coming up to midpoint. So more of the background and more of the baseline stuff that I'll be talking about today. So in order to collect these data, what we did is Borshika was so generous to provide us some different interview protocols and interview scripts that she's used previously for PRISM. And with her help, we adapted those to kind of meet the needs of what we were trying to look for. And I'll show you for those who might not be as familiar with PRISM, I'll show you the different domains here in a minute. But what we did is we conducted 26 Zoom interviews with, again, like I mentioned, 3 different groups of previous learning collaborative implementers and participants. So talked to some of the KREC members themselves, because I was interested in what their perspective was on implementing the DLC. There were 5 that I talked to. Clinic practitioners and staff, I did focus groups with that. There were 4 of those, total of 13 participants. And then health department partners who, like I said, provided those free DSMES services for the clinics that did not offer it themselves. Coded the interviews deductively and in vivo based on those PRISM domains that were operationalized and refined for the projects. Found the codes that were grouped then into overarching themes to describe some cross-cutting implementation determinants, which is what I'm going to be describing here. So just briefly on the results, which of course I'm going to dive into in more detail here. And again, this will make more sense if you're not as familiar with PRISM when I show the diagram of PRISM momentarily. I don't know exactly how much discussion's been done on that previously. But participants most frequently listed determinants that acted as both facilitators and barriers to implementations related mainly to 3 domains in PRISM. And in this case, it was focused on implementation and sustainability infrastructure, which I'll just pause and mention that the clinics that we're working with are primarily rural Eastern Kentucky clinics. So if you think about different determinants of implementation, one of the things that really makes sense, if any of you work in rural environments, is infrastructure is a huge barrier oftentimes. So it makes sense that that was pretty much the leading domain that people were referring to in a lot of these conversations that we had. Organizational perspective of the intervention, and then organizational characteristics as well. The 3rd one, of course, I think also makes a lot of sense when you're dealing with smaller rural primary care clinics. The characteristics of that organization oftentimes have very strong influence on the success of implementation. In this case, the resources they have, the turnover they have, et cetera, which I'll talk about. So responding to these determinants, our implementation partners, and in this case, I'm talking both about KREC and the clinics in this case, utilize various different strategies and adaptations that impacted outcomes, which we'll talk about here. So again, this is I think Borshika, I think this is the newest one that I've seen anyway on PRISM for diagrams in this case. So if you look at it, there are various different determinants that impact these REAIM implementation outcomes, reach effectiveness, adoption, implementation, and maintenance, which you see at the bottom. Obviously, in this case, we were focusing more on these determinants because we were collecting these baseline data. So we were looking at how various aspects of the intervention, including the organizational perspective of the staff, managers, and leaders, less the patient perspective in this case, because that's a whole separate part of data collection that we're going to be doing. And then the recipients, so the organizational characteristics of the recipients, the patient characteristics, and then we talked about the external environment, and then again, that infrastructure for implementation and sustainability, and how these things impacted the success or lack of success of both the intervention and components of the intervention, and then how we can leverage those things and try to work with some of those barriers and try to overcome some of those barriers moving forward, which is what we're doing in this third iteration. So just kind of to give you a little in vivo output spreadsheet here, if you can kind of see where the majority of codes we're showing here. So the three groups right there, again, if you're looking at the columns, are the clinics, the Healthy Living with Diabetes team, and then the KREC team. So those are the three different groups. So if you kind of look at where the major things came for the clinic, the organizational perspective was probably the most salient or the most commented. There were the most codes that I was able to pull out there. For the Healthy Living with Diabetes, it related a lot to the implementation and sustainability infrastructure. And then for the KREC group, of course, the facilitators, that implementation, that REAIM implementation code was really strong there. But you can really see kind of across them, if you look at the ones that were really the biggest, so that organizational perspective was big all around, implementation was big all around, infrastructure was big, organizational perspective, I think I already mentioned, and organizational characteristics. So these were the ones that really kind of stood out. Certain ones were not as big at this point, like maintenance or reach, because the groups I was talking to didn't really have as much to talk about on that. And we were focused again more on those early determinants as opposed to the outcomes in this case, which we are going to be focusing on much more heavily toward the end of this third iteration. So just to kind of go into some of these domains before we talk more about the strategies and the adaptations that they did, I'll talk a little bit about these different determinants that kind of led to those different outcomes and how those adaptations and how those strategies came around. So organizational perspective, we operationalized as the overall perceptions of the learning collaborative from the implementer's perspective, and facilitators and barriers related to the learning collaborative structure itself. So some major themes that we found is that it was a lot more work than expected, as you know, folks a lot of times go into these things not really knowing what they're going into, but it was helpful due to the small tests of change that were kind of baked into the IHI breakthrough model. And they were able to track their quality scores across the entire year. So they were kind of able to see how they were progressing with the learning collaborative and how it actually made a distinct impact on their quality scores that they were tracking in their EHR. So those were things that were discovered in this case. And I won't read the exemplar, but it kind of goes along with what I was saying there on how they were able to look at those improvements and actually see those tangibly and be able to track those. So again, summarizing some of those things there that were in that, some of the major things were, I think the breakthrough model itself from IHI was very helpful. Obviously, KREC has been using that quite often, so they're comfortable with it, and the clinics, it made sense with them as well. And I see also, just to pause, that Borshika mentioned in the chat to make an effort to operationalize the domains in the study. And yes, that was extremely important. And it was one of the things that Borshika and I actually went back and forth on how we can operationalize each of these domains for PRISM, because you'll read a lot of these different articles, and you have to think about how these different domains, how these different constructs, however you want to say them, make sense for your study. So we really went back and forth on that. And I mean, Borshika, I would say we probably had at least 2 or 3 calls and multiple emails before we got to the point where we were comfortable with coding. So making sure that we're all on the same page and coding properly was really important. So other organizational perspectives, the individuals participating were very happy to have advisory boards with topical experts who took part in As part of this learning collaborative, they had these monthly calls. So they would bring in topical experts to talk about issues that were affecting the clinics and that they were concerned about. And they thought that was a strength. However, one of the things that happened from the very first learning collaborative to the most recent one is the calls got larger with more people. And what we found with that is that especially with the smaller clinics, there was less participation. So on the plus side, there were more resources when there were more people in the room. On the negative side, the more people that were in the room made people a little bit more reticent to speak up on issues because they were uncomfortable. They felt that maybe it was something that was wrong with their clinic as opposed to an issue that other people would want to hear about. So somebody asked me here also if the advisory board included patients or their representatives. The advisory board is mainly topical experts in this case and folks who work in the clinics. I think they may have had a patient in the one diabetes learning collaborative, but I don't know if they had patient perspective in the other one. But that is a really good question on that. And the way I've set this up, because this is a version of a presentation that I've given to my team, and then it's also based on the poster that I presented, is I don't have a ton of breaks built in here. So please, if you have questions, throw them in the chat. I will pause and I see them pop up on my screen. So I will gladly answer anything. If you have them, please keep putting them in there.
I will say, Aaron, that you are one of the few presenters that can do presentation and seamlessly bring in the comments. So bravo.
Oh, thank you so much. I don't know if it's a good thing or if it's just a sign of the fact that we lived in COVID so long that I unfortunately or fortunately got better and better at doing this, I guess. So, and actually this goes to an adaptation in this case. So we're going to talk more about this later. But one of the things that they added in, and when I say they, I mean KREC added in, were individual calls shortly after those group calls with the clinics and the health departments, so that clinic staff could speak a little bit more freely about some of the issues that they were encountering and didn't feel necessarily as nervous talking on those larger calls. So that was considered to be a very strong strength when they added that in right there. Oh, look at that. Thank you, Prajakta, for adding in that extra, that multi-level nature. I really love that. And I'm going to make sure to save this to my computer before I go, because that's a really, really cool diagram. Thank you. Moving on to organizational characteristics. So again, still with the recipients domain here in this case, we operationalize this as the roles and description of roles for the implementers, the specific roles in the learning collaborative for participating or implementing the strategies, and then the characteristics that helped or hindered participation as well, which we'll talk a little bit about all of those. So some of the themes here are strengths within this theme included having caring and resilient staff who are willing to go above and beyond with patient care. And I'm going to pause a little bit because this is something that I've found in colorectal cancer screening and in various other issues that I've worked in rural environments in particular. And it kind of links in with the next one as well, of having a strong clinician champion, is having at least somebody on the team who's really passionate about this, who's willing to go above and beyond. Because again, if you've ever worked in rural or under-resourced environments, oftentimes it's not necessarily that they have the extra time in their schedule to kind of champion these things. It's that they really have a passion about it, or that they really have a desire to work on this, whether it's something that's affected them personally or it's something that they've seen in their patient population. Having that buy-in is really strong in this case. And with this learning collaborative in particular, having a strong clinician champion was considered a strength. So somebody who could understand it both from the medical perspective and then could kind of, for lack of a better term, rally the team around participating. And then lastly, and again, this speaks to just the practical nature of working in these smaller clinics, is having a quality assurance or a technical assistance person on staff to help with data validation. Smaller clinics working with their EHR would often have to, if they ran into problems, would have to call a centralized 800 number and wait on hold, just like you or I have to wait on hold for technical support when we have an issue with our computers. And if you've ever done that, you know that that's not exactly the most fun time in the world. So having somebody on staff was considered a facilitator, as opposed to having that centralized call in this case. And then again, we already talked about having too many partners on the DLC session. So not just necessarily the visiting speakers and other folks, but in these early iterations, there were the KREC people, and then there were some University of Kentucky people, and then there were some Department for Public Health people, and there were just a lot of top-heavy individuals, I guess, in those calls, which kind of had a chilling effect on some of the conversation in this case. So you can see in the exemplar quotes there talking about a provider champion and some of the other issues there. And I'll go through some more of these as well. So some of the characteristics of the organizations on the clinic side, consistency of staff. This is kind of, again, one of those obvious things, I think, in this case. It's a lot easier when there are fewer turnovers. I've worked on other projects in Eastern Kentucky as well. Actually, for both Projecta and Borchka's sake, for the Access program, one of our 5 clinics, we've had, I think, 4 or 5 clinic champions from that same clinic because there's continued turnover. And naturally, what that means is it's starting over again to some extent every single time. And it's very tough to actually get the strategies that you're trying to implemented when you have to start from scratch every single time. So again, that consistency of staff was considered a strength. Having a strong provider champion, we talked about, and having a quality assurance health TA person on staff. From the health department perspective, they don't have support staff to assist with the DSMES that they were providing the clinics. So their goal, their main role in their diabetes educator roles that they had, which most of them did, that was their actual title, was to do this DSMES. But on top of that, they were also scheduling the DSMES and doing all of the administrative tasks as well, which was above and beyond their mainly part-time 20-hour-a-week role. So they were ending up doing double the work really and they didn't have time to do that. So as a result, it made it really difficult to offer as many services. One thing that I heard is if they didn't have to make multiple calls and follow up with people and register people, they would probably be able to offer more versions of the DSMES at different times for different people, which would, of course, ostensibly make it easier for more people to participate, but they were unable to do that because of that administrative headache. And then from the KREC side, characteristics of their organization that help support, they've built up rapport with these clinics over years. These clinics know who KREC are, and they know these individuals. They've interacted with them. They're comfortable with them. So it's very easy for them to get clinics to buy into these things and agree to participate, which, of course, is really, really a great resource to have. And they're actually housed under UK healthcare. So it's easy for us as researchers to work with them too, which is a really nice resource over here. And individuals within the KREC group have unique strengths that they said complemented each other without duplicating each other's roles, which was really nice. Also, again, we mentioned how TA was an issue for some of these clinics. They have folks who've worked in TA for many years on there, so they were able to provide TA on a one-on-one basis as needed for clinics, including data validation and EHR help, as well as practical assistance, helping keep things moving, so that a lot of these gaps and a lot of these barriers were able to be filled with some of the different folks in KREC, which was allowing it to be a successful learning collaborative overall. So moving on to the next domain here, which refers to external environment. Where did I lose my mouse? Sorry, there we go. And we operationalize this as facilitators and barriers related to external factors, whether that be at the regional, state, or federal level. Major theme here wasn't a ton in external environment, but the major theme here was that mandated reporting. So Uniform Data System, UDS, or HEDIS measures, some of the measures that a lot of these clinics are required to collect for their quality metrics, helped guide the metric selection for the clinics, the main goals that they were trying to fix. Obviously, A1C was the primary goal that everyone was going for, but then they picked secondary goals and measures as well, whether that be foot tests, whether that be a variety of different things. They were able to kind of pick those. They tended to pick those based along what they were getting measured on for these quality metrics. And the DLC tended to be most successful, and clinics bought into it more when it aligned with their priorities. So if it was one of those things that was able to benefit them very directly, they tended to be more involved in it in this case. So again, mentioning how those helped enforce or incentivize the activities for the clinics. Some clinics took it upon themselves to do some other things to help their patients, take those DSMES lessons and apply them. One clinic in particular was able to use double dollars to the farmers market. This is available in various different states or various different versions of this, where individuals who rely on WIC or any of the other types of food programs, in this case, food assistance programs, are able to get double that money if they use it at the farmer's market in this case. We had that available here as well. So one clinic was able to use that. So another external environment is in-person DSMES. Some folks, especially if they're older, still don't feel comfortable doing Zoom DSMES and they want an in-person DSMES. Unfortunately, that's less available in rural areas. You may have one location per county. If you know anything about Kentucky, most of our counties are small. We actually have the third most counties of any state in the United States, which is very strange for a relatively compact state. But there are still some counties that are relatively large. So you might still have to travel an hour and a half if you wanted to attend an in-person DSMES. That said, overall, again, the DLC was most successful when it aligned with clinic priorities, which were often related to those measures. We're going to talk a little bit about also the in-person DSMES available in the rural areas and some of the adaptations that they made about that in a minute too. So, and finally, before we go to some of these re-aim outcomes, the last domain here is implementation and sustainability infrastructure, which was operationalized. Again, very strong in this study. This one showed up quite a bit in our conversations. Related to facilitators and barriers, about resources or support, or in this case, a lot of lack thereof resources, and how it affected activities to support implementation. So some of the major themes here related to staffing issues with smaller organizations. They just didn't have as many people on board. Technological limitations. You'll notice that some of those things kind of cross-coded in this case. They showed up on a couple different domains in this case. And technological limitations, depending on how it was discussed by a particular participant, coded in two different areas in this case. And then more front end, one of the things that they found was a facilitator of success was more front end technical assistance work equated to greater readiness to participate in the DLC. And the third quote on the exemplar, I think, is really important there. It says the more work that you do on the front end in preparation is key. So then you can work on your data, your reporting, and get your goals in place before the collaborative actually starts. And one of the things that they found out early on in the first iteration is that there were a number of clinics that were just not ready or didn't have the TA capacity to get their data validation ready prior to the DLC participating. So they spent those first 2 monthly calls and sometimes into the third monthly call actually working on technical assistance. So these clinics, there were a few clinics that were, 2 months behind the other clinics actually putting their tests of change in action because they were still working on data issues. So having those pre-work and those pre-calls we're able to get for the second collaborative, the second iteration of the collaborative, were helpful to do that. And Russ, I see that you mentioned if there's time, might be fun to discuss the implementation of sustainability infrastructure in more detail. And it's one of the domains that's often least well understood. And I agree. And working in rural Kentucky, it's actually one of the ones that comes up probably the most in my work, not just on this, but in other things that I've worked on in PRISM. We find that, there's a lot of great programs that we have and a lot of great evidence-based interventions that we have, but the infrastructure just to implement them a lot of times is severely lacking, which serves as a barrier. And then not even talking about sustainability, a lot of times when we step back, the infrastructure a lot of times is provided by the university. And then when the university is not there, it becomes difficult to sustain. So if we have time, hopefully we'll get a chance to talk about that a little bit more. So again, with that infrastructure, one of the things, again, I would consider structural in this case because it relates to the health system, is more buy-in from the top. In this case, not just practitioners, but CEOs. If the CEO was behind it and kind of made it more of a mandate and said, we need to work on this, it tended to involve more buy-in and more participation. Talked about EHR issues a little bit already. Smaller clinics said that they found it difficult to participate because they would have staffing needs And, sometimes they would have to leave the Zoom to go deal with a patient and then come back occasionally. So these are a lot of very, real world issues that happen when you're dealing with smaller primary care clinics. Is it may be very difficult for them to take an hour or an hour and a half and sit in front of a computer if there's only a handful of staff on board. One of the things that we found helped sustain the program afterwards when we were tracking, especially with that first iteration, is that integrating DSMES referral into their standard workflow and building that workflow if they didn't have it was integral in order to make sure that this continued on. One thing that they found and that the clinics mentioned is you can't rely on a particular project champion or a passionate clinic staff for sustainability. And one of the great examples that I heard, or I shouldn't say great examples, but one of the salient examples that we heard is one of their providers was extraordinarily passionate and then got very ill and was out of the office for almost 6 months. And the rest of the clinic staff just kind of watched the project drop off because it was really the motivation and the emphasis and the passion of that particular provider that geared up the staff, and they didn't have a workflow in place, so it kind of tumbled down at that point. So having that workflow was shown to be very important. And from the KREC perspective, in this case, having a good data plan and infrastructure in place before the DLC starts, like I mentioned, with that pre-work was really important. And then again, clinics who had someone on staff to handle IT support rather than a ticket to the vendor, that was an infrastructure that was extraordinarily helpful for them. So moving into these re-aim outcomes and talking a little bit about strategies and adaptations here, keeping an eye on my clock up here to make sure we have enough time for questions afterwards as well. We operationalized implementation as the people who selected in the process of selecting primary and secondary metrics in the Learning Collaborative, as well as strategies that supported initial and an ongoing implementation of the initiatives and adaptation, including the timing, the decision process, and the perceived outcomes of those adaptations. And I should say that, this was all collected ex post facto. So these first 2 iterations, there wasn't anybody tracking these adaptations using a framework like the Frame IS or anything like that. So a lot of the data that I got were people remembering things that happened previously. However, for this 3rd iteration, which is something Borshka and I were actually talking about right before this call started, is we're actually going to look to track these adaptations, why they happened, who made the decision, what type of adaptation, was it planned, unplanned, et cetera. So we're going to have a little bit more concrete knowledge about why these adaptations and then also why these strategies were selected and based on what. So some of the themes that we found here on strategies, some of the things that were helpful is one of the main ones was integrating progress toward the selected goals that the clinic set into their morning huddles to help refocus them and help them decide where to focus their efforts for the upcoming time period was extraordinarily important. And then also one of the things that the health departments mentioned, which is not as important in this one because we're not working with the health departments directly, because again, like I mentioned in this current iteration, our clinics all have their own in-house DSMES. But for these previous ones, the clinics would refer patients to DSMES, but they would not prime them and let them know that the health department was going to call them, so they ended up thinking that it was a spam call, or that they were asking for money, or that it was something completely different, or they wouldn't answer the call at all, which made it very difficult for the health department. So for that second iteration of the DLC, the clinics were told to give them a primer, whether that be a primer letter or usually a handout in the clinic that said, you're going to be receiving a call from X health department. This will help you. You'd be prepared for this. They're going to be scheduling you. That made it a little bit easier. Some adaptations in this case, obviously the very first one started out in person as a learning collaborative, and it was right in the middle of COVID, right around that time where the entire world shut down, so they had to shift to a virtual format. That was, of course, the largest adaptation. We also talked about that early data validation before the first learning session to make sure the clinics were reporting similarly and using standard methodology. And then that addition of monthly technical assistance calls, which allowed the clinics to speak on their own specific issues that they may have felt uncomfortable speaking about on the larger calls. So making sure, I cannot see my chat here, so I'm making sure I don't have anything in the chat real quick. There we go. Okay, I don't. Good. So some of the strategies that clinics implemented, one-on-one health coaching was something that one of the clinics found really helpful. A couple of the clinics, especially during COVID, implemented remote patient monitoring, monitoring patients' weight, blood pressure, pulse ox, and glucose remotely, so that individuals who were not able to come into the clinic, they were still able to check on them in that way. Integrating progress to the morning huddles, as I mentioned, and then having a diabetes educator call no-show patients to get them rescheduled was also helped to keep patients from dropping off in this case. From the health department, I mentioned that primer was important in this case because it made it more difficult to schedule. And if you think back to what I said about some of the health department employees, it was very difficult for them to offer DSMES services at the quantity and level they wanted to because they were doing so at many administrative tasks. And when there was no primer, those administrative tasks were even more burdensome. So what we found is they said, anecdotally in this case, on the second learning collaborative, it was a lot easier when they had those primer letters and when patients knew that they were going to call them. And then more front-end support from the clinics to determine patient needs for DSMES, because again, like I mentioned, some patients would prefer an in-person via Zoom. From the KREC perspective strategies, they used support for clinic DLC activities. They used a variety of different things, storyboarding, PDSA cycles, provision of supplies. When they moved to Zoom, they had to make things a lot more interactive. Just naturally, things tend to be more interactive when we're in person and we can read people's eyes and see if they're paying attention. It became more important because a lot of times, and this happens with a lot of the clinics I work with as well, they're able to connect on Zoom, but they don't have a camera on their computers. So you never get to see them the entire time. You hear from them, you talk with them. So they started adding things like on-screen annotations, human-centered design, polling features, things that they could make sure people were still paying attention and that they were still engaged that way. And then helping clinics determine reasonable goals and measures so that were smart and reasonable. So a lot of times clinics would try to come up with a measure that was way too lofty for a small test of change, and the KREC was able to help work with them to bring those back down to earth a little bit. So some adaptations that were done based on some of these different things that we discussed, some of these different determinants. Clinics, some of the clinics shifted from community health workers to medical assistants and providers leading the referrals because patients were more comfortable with there's still a lot of stigma with diabetes in rural Appalachia, and the community health worker didn't feel as, I guess, medical or professional as a medical assistant. So they were more comfortable having a provider or medical assistant do those referrals. So that was a shift that they did. And then one of the big ones was the development of a provider workflow or an appointment agenda in this case, so that the provider knew exactly what to do. So quickly order the A1C test, the foot exam, et cetera, and get the DSMES referral. Because again, these providers have limited time, and when they're in that limited time frame and patients are coming in for other chronic conditions and or acute conditions, they're not necessarily able to do all those steps. So having that really quick workflow was important to them as well. And I see that Mustafa just mentioned staffing is a strength in this project, but then nicely highlighted that integrating to workflow is essential for sustainability. And then the question is, when is the best time to start this integration activities? I see some issues with starting too early, and obviously late integration is also an issue. And to give an example with the 6 month, the provider that was out for 6 months with a serious illness. That's a really great question. You obviously can't you obviously can't develop the workflow at the very beginning because you're still validating data and you're still starting with the smallest tests of change. I would say by the time they see that first or second test of change, and in this learning collaborative, they undergo multiple PDSA cycles. So every month they're doing a small incremental increase on what they were doing before. So by the time they actually start to see it working, which is usually after maybe the second test of change, I think that's a really good time to start integrating that workflow and say, this is great that you all see this. However, you will have other staff that come in. There will be new people. Some of you may leave. Someone may get sick. We need to make sure that this is understood by anyone new. So let's talk about developing a provider workflow. And we're on the, I think, 4th learning session right now for this 3rd group, and they've all developed their workflow at this point. So that's something that we've kind of put into the DLC at this point. So thank you for that question. Adaptations from the health department. This was actually an interesting one. So there are only so many health departments that have certified diabetes educators. And in order to be a certified DSMES program, you have to have a certified diabetes educator. There are various other individuals who are capable of doing this, but they're not a state certified DSMES. So there's, sometimes one health department in a county that has the certified diabetes educator, but there are various other satellite health departments within that county and in different cities. So what we would do is, for those individuals who wanted the in-person session, is they would zoom in they would zoom in the certified educator from the non-certified place at one of those satellite health departments, so people could come in and still receive certified DSMES, but be in person. So the individual who worked at the non-certified place could actually facilitate the activities and make sure everybody understood, but they were receiving the information from that certified educator, which I thought was actually quite innovative, for them to think about this and come up with that. That was not anything that was suggested to them. That was their idea. And then, of course, the shift from in-person to Zoom. It allowed for continuation of Zoom because people were able to participate more, often scheduled during lunch hours, which made people more able to participate. They could eat their lunch at their desk and participate in an hour and a half call. One of the downfalls, again, was you didn't have as much conversation. You didn't have as much ability to see people and interact with people. But what we heard was that the pluses overweighed the minuses, because a lot of these smaller clinics said if it were in person, we had to travel, we just wouldn't be able to participate, period. We don't have enough people and we couldn't give up that time. So they're sticking with that. And then KREC, again, the shift was considered positive on their end too, much to their credit, by being able to be very interactive in their Zoom presentations. The early data validation was an adaptation, extending the data reporting period to account for longitudinal measures that may not be available at specific reporting time points. So to see some of these longer changes, they needed to extend that reporting period. They found that out very early, so they did that. That addition of monthly TA calls, and then having clinics being assigned, not just a single DSMES partner. Originally, they were assigned just one health department, but now they're assigned both a primary and a secondary, at least in the second one, when they have these health department partners, which was able to accommodate different patient needs and schedules and health department limitations. Like I mentioned before, some of them aren't able to offer various different time frames that patients might need. So having that primary and secondary partner was a way to kind of work around that. So just in summary here, before I finish up, because I know I'm getting close to my time, some summary and suggestions here is, again, having that clinical leadership buy-in and a provider champion who can participate, and then a mechanism to involve other clinic staff. Obviously, the workflow is one of those, but those huddles are another way of just making sure that it's on everybody's radar, so that it's not just a group of 2 or 3 people that are really running this. You need to make sure that everybody knows about it. That emphasis of alignment with existing measures does a really good job of getting that initial buy-in and keeping people engaged in the DLC. And again, what I mentioned here is that, like, some clinics said that a hybrid format will be useful. Small clinics in particular, and especially providers in the small clinics, said that in-person would simply not be feasible. Not a single person, I should mention, said that Zoom was unacceptable. So in this case, it's not perfect, but it tends to probably cast a wider net than if we went back to in-person. So plans moving forward with this third iteration that we're in the midpoint, or getting into the midpoint here shortly, is this identification of determinants and their effects are being used currently to refine this DSMES focused DLC that we're working on right now, that is incorporating these adaptations, and then tracking, again, other unplanned midpoint adaptations, which is what we're going to be learning about here hopefully soon. So, hey, Borshika, maybe in another year I can come back and give a speech on the same group, but we'll talk more about how we tracked these strategies and adaptations and where and why they happened. And then what we're going to be doing is evaluating the pragmatic implementability of the collaborative by looking at feasibility, acceptability, and sustainability via stakeholder and participant surveys, as well as various different pieces of data. So that's what I have to share with you at this point. I hope that was useful. I got some good questions in the chat already, which I hopefully answered appropriately. But if you have any other questions, I am here. And I always tell people, if I took down the PowerPoint too early, There are only 2 Kruse-Diehren in the entire world, myself and my husband. So if you're looking to try to get a hold of me, all you have to do is Google Kruse-Diehr, and you will find me very easily. And I'll be happy to answer questions if you think of them later on as well.
Thank you so much, Aaron. Very well done as usual, just very concise. And thank you for addressing the questions as they came in. So let me open it up for a little bit of discussion. We have about 8 minutes. I do have a couple of questions, but I don't want to take up time. So I would like to hear from you all. And if you want to, if you are in a position to turn on your camera, unmute, feel free to jump in. Or you can use the chat, whichever is more comfortable.
Aaron, can I jump in? Just
Yes.
a quick question on, as you were talking about adaptations, it occurred to me like there were adaptations to the process, and then there were adaptations to the intervention,
Yes.
and then there were adaptations to the strategies.
Yes.
Could you just comment a little bit about how you were thinking, or how did the model, the PRISM framework, sort of help you think through all of that?
Yeah, no, that's great. And to be quite frank, Prajakta, when I was looking at adaptations, because we didn't really, this was never done with a framework in mind the first 2 times, I think. I kind of used adaptations as a large melting pot or a gathering space of all adaptations. And exactly what you said, which is something that I notice as well, is these adaptations are not the same. They're very different types of adaptations, which is why we're doing a much more, I think, what's the word I'm looking for? A much more thoughtful process of trying to measure these adaptations for this third DLC, which is why we're looking at using potentially the Frame IS or a version of Borshka provided me with a different adaptations matrix that she's used before that kind of tries to categorize those adaptations. And that's actually what we're going to look for moving forward, because the goal with this is to actually scale this up into a larger R01. And I think we're going to really need to know exactly the different types of adaptations, when, where, why, who put them into place at what point, and what types, again, like you said, of adaptations they are. I think that's extremely important to know as we move forward. So again, because this is all ex post facto and we never really looked at that moving forward, and a lot of people were remembering things that happened a year or 2 years ago.
Yeah,
we weren't really able to kind of categorize those various things with any accuracy, but we're certainly trying to do that in this third iteration.
but like Borshka and I've tried to do is, instead of like even having the people categorize it as scientists, we could like think about it a little bit more in depth on like, what does this mean for the strategy versus what does this mean for the intervention?
I think that's a great idea.
That might be fun to do, just to get more clarity around some of these adaptations.
And I think that's probably a really good, and I appreciate that. That's actually a great idea. And once we're very close to collecting these midpoint data, and as soon as we do, I think it's going to be really interesting to kind of do some of that categorization.
Super. Others? Sarah, please.
Hi, thank you so much. I really enjoyed that. I am wondering, kind of, it's great how many practical implications this seems to have in your results. So I'm wondering, like, what's your strategy for actually taking that and like improving the next round of this, or like, what does that look like? Or for other people who are implementing this?
Yeah, no, that's a great question. And really one of the wonderful things about working with PayRec is they're a quality improvement organization. So it's kind of a wild thing. They do quality improvement with all these clinics, and we're doing quality improvement with them. So they've never really experienced that, but at the same point, their brains are kind of wired to quality improvement. So they're used to the process of iterating through these things. So they're actually taking, I obviously shared all of this information back with the team, including them, and they've taken these and thoughtfully put them into their team calls, and they're using these adaptations and these strategies in this third iteration, and then they're tracking those moving forward. I think when we scale it up, because again, we're only working with 2 clinics right now. So when we scale it up and across the state and work with more clinics, excuse me, I think there's going to be an extremely there needs to be an extremely thoughtful process, going back to a lot of what Prajakta said in this case as well, of categorizing these adaptations and these strategies, why they happened, and then being able to work, doing some of this pre-work with the different clinics that come in and say, you know, clinics that were similar to you based on various different demographics or circumstances found that X, Y, and Z were helpful to help them implement this, and being able to put that into practice. Because again, these clinics are different in size, they're different in capabilities, different in staffing, and they have different patient populations. So being able to kind of look at where those changes occur, which we're able to start getting some of that granular data. You know, unfortunately, I think even with the R01, we're still going to be a little bit in the learning process at this point. So I don't think it's going to be super granular, but because we don't have every type of clinic, just they're not all, you know, represented in these data yet, because we just haven't worked with that many clinics yet. So we're still going to be learning, but I think we have enough that we're going to be able to kind of at least hypothesize of what sort of strategies might be needed to help implementation success for various different types of clinics. Russ asked which PRISM domains were easiest and most challenging to operationalize. That's a great question. And I have to really think back, because it's been probably 6 months since I did the actual coding on this case. You know, weirdly enough, I thought that implementation and sustainability infrastructure, and maybe it's just the data that I had from our participants, was one of the easier ones, because one of the things that I always think about when I'm working in Eastern Kentucky, lower resource Eastern Kentucky, is the infrastructure. It's very challenging. We do, you know, for another example, a lot of the different things that people have done for colorectal cancer screening are phone apps and things like that. We can't necessarily do that a lot of times in Eastern Kentucky, because we don't have strong high-speed internet, and a lot of folks are not used to using their phones for these sorts of things. So we have to really think about the types of infrastructure that we have available to do that. I would say, let me try to think of which ones were more difficult. I think characteristics of the organization was a tough one to really tease out of people, because people want to immediately talk about how great their organization is, and they don't want to say any of the negative things about their organization. So it's really hard to try to get people to, I think, be honest with themselves about where can we improve as people, as skill sets, as what are we missing in this case. So I got a lot of really great data about the strengths of the organizations that were involved in this. I got probably less useful data about the, if not weaknesses, areas in need of improvement. So I think that's just a tough one on human nature to get people to talk about.
Super. I'm looking at time. We only have 1 minute left. I had 6 questions for you, Aaron. Good news. You and I are going to meet anyways. So I'm going to use those for that. I'm so glad that you all were so engaged. Thank you so much. Thank you, Aaron, for being here. This was a great start, very engaged discussion. And we look forward to connecting with you all in February. Aaron, we will add you to the list as you request.
Please do. Yes. I want to see Prajakta's presentation. Absolutely.
Super. And thank you again. And thanks for everyone for joining, and Happy New Year.
Thank you, everyone. I appreciate it. Have a good one.
Bye.
Bye-bye.